Welcome to RhAPPcast, the official podcast of Rheumatology Advanced Practice Providers, where we bring you practical insights, clinical expertise, and real-world perspectives to support your care of patients with rheumatic diseases. I'm your host, Amanda Mixon, and in today's episode, PharmDs in Rheumatology, we're taking a closer look at the evolving and increasingly impactful role of pharmacists within the rheumatology care team. From navigating complex treatment regimens and safety monitoring to improving access and supporting shared decision-making, PharmDs play a critical role in optimizing patient outcomes. Today, we'll explore how that expertise translates into day-to-day clinical practice and, more importantly, the practical pearls you can apply immediately in your own setting. I'm joined today by RhAPP board member Danielle Gatti-Palumbo, who brings a wealth of experience and insight into pharmacists' role in rheumatology care. Danielle, thank you so much for being here.
Thank you, Amanda, for having me, and thank you for highlighting pharmacists in rheumatology especially.
Well, I can't even begin to say how much I appreciate you. As you know, I have sent you multiple text messages about patients that I need help with. And so the role is just growing. And I just think this is such an amazing platform to be able to highlight what all pharmacists do. So let's go ahead and start right away. Can you describe your current role in rheumatology and how PharmDs are typically integrated into a rheumatology care team?
Yeah, so I will say that no matter where you go, no matter what state you're in, pharmacists are very unique. So we don't always look the same in every single practice. We have some pharmacists in rheumatology that are solely housed in the specialty pharmacy within like a hospital network, or we have pharmacists that are specifically housed in the clinic or the outpatient office, ambulatory offices. And then we also have rheumatology pharmacists that are also partnered with colleges, right? And they may rotate between different clinics. Me, for example, I am solely housed within the rheumatology office. So I sit with the providers. I'm always hand in hand with the providers. We believe in more of like an out of sight, out of mind kind of, or insight in minds kind of mentality. So I like to be physically with the providers as well. Because I'm always here if they have a question, if they have a patient in the room that needs counseling, so they'll pull me in for that. I have a patient that's complaining of this weird side effect. Can you look into it for me? I have a patient that has tried and failed this and this medication. So being within the practice, being that point person, and then also being a liaison with the pharmacy. So they get their medications filled at usually our hospital pharmacy, but being that point person. So we kind of are like a liaison between pharmacy and also the practice and the patients. But that's kind of where my atmosphere is within the practice.
From your perspective, where do you feel like PharmDs add the most value when we're talking about the management of patients in rheumatic disease?
Yeah. So basically, I think the best and most valuable part of having a pharmacist is being that point of person for counseling on side effects, on managing side effects. Oftentimes, patients will call the office for side effects and they'll speak to me or the nurse. And then we'll kind of manage it from there before even going to the physician. If it's something that we need to escalate to the physician, then we will. There's also a lot of dosing regimens. And if you know rheumatology, there's a lot of steroid tapering. There's, Savella tapering. There's Otezla tapering. There's all these different Taltz, forget it, depending on the indication, right? So a lot of times patients will get confused. And with all due, with respect, it is confusing, especially for a patient that doesn't really know what does week 0 really mean? What does week 4 really mean, right? So a lot of counseling, because these medication regimens are not always so simple, right? Okay, do I start this medication on this day or do I have to finish or wait a week from my last medication, right? To start the new medication. So dosing regimens, also infusion drugs. When there's new infusion drugs, we often will work with the nurses on like how to administer these drugs, like does it need to be in a specific bag or do we need a specific pump? Those questions have come up, especially with like IVIG and so QIVIG. So those drug information messages kind of come to me and then we kind of figure it out from there. So definitely counseling, side effect management, and then also trying to find that best regimen for the patient.
Well, it's interesting you said, it can be challenging for the patients, also very challenging for the providers. Um, I know for sure I can't remember how things are dosed, unless I've, done it 100 times, but particularly as this field is evolving and we have newer therapies, I know just having that ability to call someone and say, "How do I dose this again? This is the diagnosis, but they also have this," right? Like, maybe they have psoriatic arthritis, but they also have psoriasis or Crohn's. So, like, understanding that different therapies have different, regimens that we should follow. And, IVIG, forget about it. I can never ever remember how to dose that. Like, how many days should it be over? I mean, these are the things where having a clinical pharmacist, I think, is so important, obviously for patient compliance, but patient safety. So, I mean, again, I feel like you all are worth your weight in gold for some of those therapy questions too. And these diseases are complex, as are the treatments. So, I'm sure that you're involved in making some of these treatment decisions. So, how do you approach treatment selection and optimization in the collaboration with the care team?
Yeah, so a lot of the optimization of like complex regimens, right? When we say like basically a lot is driven unfortunately by the payers, right? The insurance payers. Like what can we choose, right? We need a TNF or we need a IL-23 inhibitor. So we are oftentimes stuck with whatever the payers will pay for. But from there, even working with the biosimilars, the providers want like a Humira, say example, but then there's so many biosimilars. So what we do is we kind of right now we have like a blanket kind of oral agreement that we can switch the medication to whatever biosimilar is covered, right? And then we'll do the counseling from there that we're switching you to a biosimilar and X, Y, and Z with the counseling part. In regards to like if a provider wants a specific class of medication, we'll then switch to whatever is the preferred agent in that based on that insurance. A lot of times providers will just ask, well, what is covered under this person's plan? I don't know half the time because there's so many different carve outs within the same insurance that they look like it may be this, but then it's actually really not. So kind of going with their first, what do you want a patient to be on? And then we'll go from there. Oftentimes we will also appeal because if that provider wants that specific medication, there's a reason, right? Whether it's a history of failure of other medications, it's comorbid conditions, it's the patient wanting something dosed monthly versus every other week. Or maybe they're having, side effects in between, like lack of efficacy or increase in symptoms every other week. So we need to increase it to weekly. So kind of having that knowledge, I think also as a pharmacist in like, the guidelines, what do the guidelines say? How to dose regimens? If a patient's having flares in between regimens, how do we get this medication approved? We can't get this medication approved, but what can I tell the insurance to get this medication approved? So having that background knowledge, and oftentimes providers will just kind of agree with us, right? They'll allow us to appeal without even, asking for any feedback. So I think having that also trust with the providers also, and having that autonomy to deal with, finding the right regimen for the complex patient.
Well, and I think that kind of gets to the next piece, which is safety, right? Safety and monitoring. Where I work, we actually just started working with a clinical pharmacist who's going to be monitoring our labs for our patients, which is incredible. Like, that is just so helpful. That's where, having, that perspective and having that knowledge is, so important for our patients. What do you feel like in terms of the safety and monitoring considerations that PharmDs can help manage in a rheumatology practice?
So, I will say one thing. So, if you work with any specialty pharmacy, you'll probably get, or even like a mail order pharmacy, I'm sure you'll get those drug interaction, messages about a PPI with methotrexate or the dose of methotrexate. So having a specifically trained rheumatology pharmacist is also important because we can look at that drug interaction and say, no, we're not talking. We don't need to think about that. So, having these very specific side effects monitoring specific for rheumatology is important because we kind of know what to look out for, what not to look out for, right? So we have a team, like in our facility, we have a team of telehealth pharmacists that kind of run through every medication that's filled, and they'll message us if for TB, they'll monitor the patient also before starting therapy for TB monitoring, hepatitis monitoring, LFTs, serum creatinine. They'll monitor for those and then ask us, oh, does the patient need another TB test? I'm not going to bother the provider. I already know the answer, right? So I'll message them instead. So it's kind of having that extra pair of eyes though is also nice, because they're going to also call the patient in between refills, right? And see how the patient's doing. So they'll do also rapid threes on the patient. If the rapid three is increasing, they're going to notify us and say, hey, listen, I don't think this patient's really responding. They don't have an appointment. Do you think we should get them an appointment in for sooner? So having the pharmacist there to also not only monitor labs, but also monitoring rapid threes, clinical, how are they doing on their medication? Hey, you're due for your refill. Have you had any side effects? Are you responding well? Right. So those kind of monitoring and then bringing them up to the practice or the providers is really important because they're going to speak to the patient probably more so or more often in between visits than the providers will.
That's so incredible that you have a team that calls
Yeah,
patients to see how they're doing. I mean, because oftentimes, I totally agree. Like maybe we see the patient every 3 to 6 months, sometimes less. It depends on the practice and how the availability is. So to have somebody that touch base with the patient in between, and then they're going to tell you something that would trigger you to say, wait a second, it sounds like this therapy maybe isn't working for you. Like time to get back in to discuss other options. Whereas that patient probably would have just waited till their 6-month follow-up because they don't wanna, like, bug us or things like that. So, that is so incredible that you all do that,
and
and
it
I
takes
just
a lot of burden off of us, right, as the pharmacist and within the practice, because we may be counseling patients on a lot of other things, right? So it's really important to have that extra layer, which is really great. If their patient's scheduling surgery, they didn't notify the office, right? Do we have to stop the therapy? So all those kind of nuances that come up are
So
important.
basically, anything associated with the therapy, the pharmacist can help. I mean, it's again, the field is just continuing to expand. One of the first things that you said was, it can look different in every practice, which I think as APPs, it can also look different in every practice, and so it's just such an evolution. And, hopefully there will be a day where there will be an APP, a physician, a pharmacist in every single rheumatology practice, because it's only just going to lead to better patient care and the best possible outcomes.
Absolutely.
Um, you kind of mentioned already the payer situation, which, is the bane of my existence on a day-to-day basis, where you start a patient on a therapy and then, nope, they can't have that therapy. They can have this one, or they've been doing well on one therapy. And now we have to switch to, biosimilar or whatever it might look like. So obviously there's a lot of barriers. So what practical strategies or pearls can you share for navigating prior auths, denials, patient assistance programs? What does that look like for you?
Yeah. So a lot of it is experience, I will say, right? So having experience knowing that, say, methotrexate for some payers is no longer covered. But knowing that I can get a coupon through GoodRx, for a methotrexate, or knowing that I can go through this patient assistance foundation and send it over there, I can get it, for a 90-day supply for X, Y, and Z, or even mycophenolate, right? Or hydroxychloroquine. So knowing where to go is kind of based on experience, though, or who taught you how to go to that website to get this medication. Sometimes hospitals will also have a specific funding for patients without insurance, or charity contribution networks that they can enroll their patients in if there is like a patient that can't get their medication anymore. So knowing that or making that connection with your inpatient hospital pharmacy. Also, having a point person for every single drug manufacturer, having that field reimbursement phone number and name of that field reimbursement specialist for every single drug manufacturer. Because we got so big and so so inundated really with the patient financial aspect. Basically, every Medicare patient has this, this deductible that they have to meet now. And unfortunately, they're on a fixed income and they can't afford their medications, right? So we also have now a team that also will specifically dedicate their time on financial assistance. And this person, is specifically trained in working with our specialty medications. Because they're part of the pharmacy department, they also work with other divisions that also use similar agents. So if it's, dermatology, rheumatology, ophthalmology, say, or even GI, right? They all use similar biologics. Having that point person to work on the financial aspect for all those divisions for the same medication. So they're making one phone call. I have this patient from rheumatology, derm, and GI space, like where are they at? So kind of consolidating and being more efficient that way. But it is definitely a team approach. There's often times where I'll contact our pharmacy and say, hey, what's the cash price of this medication? Because I have a patient that's having trouble. Even patients, we're in New York, so a lot of patients of ours go to Florida for half the year. So our snowbirds. But a lot of pharmacies won't deliver out of state. So that's also another barrier to having the patients receiving their medications. But basically it is based on experience. That's why at RhAPP, we do have like pharmacy roundtables that we kind of go through this and kind of explain like all the barriers that even mail order pharmacies are giving us, right? And then discussing them and trying to see if there's any loopholes that we can go around. Obviously, there's a lot of state restrictions on some things that we can and cannot do, but there's a lot of barriers. And that is the biggest play, I think, with pharmacists and the pharmacy teams, because it's not only just the pharmacist, but we have a whole team that's behind us as well that will help, break those barriers and get something that we can for affordable for the patients and working with them personally.
Absolutely. I mean, you're really just highlighting all of the things that you can help with. And one of the things that you mentioned was patient education. So, how do pharmacists contribute to patient education and shared decision making, particularly when we're talking about initiating or switching therapies?
Yep. So, anytime a patient is initiated on a medication, there is a counseling session. So whether that's from the pharmacy, because the patient's getting it filled at our inpatient pharmacy, so the telehealth team will contact the patient, or I will contact the patient especially if I'm in the room with the patient. So we'll do that initial counseling. We'll counsel them on what to expect. And sometimes you'd be surprised that even though we decided on a regimen, something may come up in that counseling session where it'll be like, actually, maybe this isn't the best option for you, right? So you get a lot of information sometimes just by talking to a patient and multiple different days of the week, right? You can call them on Monday and they don't complain about anything, but then by Wednesday, they complain about something. So it's really important to counsel patients, especially when initiating. Right now, we're doing a lot of switching from biosimilars, right? So a lot of times we'll counsel the patient and then the insurance, sometimes we don't even know what the patient's getting anymore from these mail order pharmacies. But then we're trying to get them, oh, wasn't the patient on the biosimilar already? I don't know. Which one were they on? Now they're having side effects. We're doing a lot of switching because they have a lot of side effects on one and then we have to switch back. And so there's a lot of counseling. There's a lot of counseling that goes into switching therapies. When do they start to take the next drug, right? Do I have to finish my supply off and then start it the next day or the next week or at the time of the next dose? So we do a lot of counseling there. But there's a lot of things to consider, especially if the patient's planning on pregnancy, right? So, making sure that if they go for any dental exams, that they need to have, that discussion with their dentist or contact us if they start any antibiotics. Sometimes providers don't have enough time to go through that during their, 20-minute, 15-minute visit, right? So during those counseling sessions, we can sometimes open up a little bit more on the patient. But yeah, definitely all initiations are getting counseled either by me or by the pharmacy that is getting filled. And then especially if any switching therapies, we'll counsel them again.
Well, I'm sure too, just having the discussion about the side effect, because to your point, I get 20 minutes with each patient, but remember, most patients don't come until like, if their appointment's at 9, they're coming at 9 o'clock. So my medical assistant has to then, so I get, exact time in the room, right? It could vary from 10 minutes to 15 I've, in an ideal world, it's 20, but I don't have time to go over every single potential side effect, and what to expect. So having a pharmacist there to talk to the patients about those things or what to expect. And, I think sometimes we forget that this is really scary for people. Like they've been diagnosed with something, they've probably already gone and read about it. Perhaps they failed some of our standard therapies and now we're talking about biologics. And they're gonna have to inject themselves. And what does that look like? And then they start to read the side effects there. And so to have somebody that has a clinical background to be able to share, what's relevant, what's not, what do we really worry about, when should you call? I don't know any provider that has the time to actually go through those things
Right.
to help put the patient's mind at ease.
Yeah. I get all those tasks.
Yes, like that, which is my gosh,
Patients
that's
calling for this, patients calling for that, or, patients calling for a refill, or the pharmacies are calling for refills on steroids, and they're not even on the steroids anymore, right?
yes. This happens all of the time. And obviously, we believe that there should be a pharmacist in every single clinic. That's currently not the case, unfortunately. But so for practices that don't have a pharmacist currently embedded, what do you think, what are some ways that providers can still leverage pharmacist expertise and incorporate similar workflows? I mean, not everybody has your cell phone like I do to where I can, ask questions when I don't know.
Yeah. So I will say that whether you're a private practice or you're a smaller practice, right? Partnering up with one of your major hospitals, your larger practices or larger networks will most likely have a specialty pharmacy. Those specialty pharmacies are specialized in specialty medications. They have certifications, right? So there's something called the Certified Specialty Pharmacy Certification, which is a certification that they go and they test for. That certification validates basically that they're trained in identifying specialty medications. They know what to look out for in monitoring in hepatitis, TB, all those monitoring preliminary labs. They know what the dosing regimens should and should not be. They know what to look out for in regards to how patients are doing on specialty medications. Just because you are a private pharmacy or a private provider's office does not mean that you can't use those specialty pharmacies with the larger network. So making that connection, our hospital pharmacy actually, or our outpatient hospital pharmacy, fills medications for private providers all the time. So they don't necessarily need to be, because they're still an independent pharmacy, they don't necessarily need to be only a provider affiliated with that network to get their medications filled. And as long as that medication's filled at that pharmacy, you're going to have access to those specialty pharmacists to counsel those patients. So I think that's number one, is to just know that, oh, I can't have a pharmacist because I don't have a pharmacy to use. You can send them to, John Hopkins, who knows, like any large corporation pharmacy, they won't limit the prescription. Oh no, we only fill for our providers, right? So making that connection with your larger hospital pharmacies, and then you'll have the access to those certified specialty pharmacists, and they'll kind of have that extra layer that is what you kind of need for your patients, right? So that's number one, I would suggest. Another option is also looking at the colleges, right? So a lot of colleges also have clinical pharmacists that are always looking for sites for putting their students in, right? So with that comes a service that the clinical pharmacist as the teacher will provide to the practices. So we have a lot of, residents as well that are located within the hospitals, but also students with the colleges that will partner up with these private practices and say they'll come in once or twice a week and, counsel patients or set up clinic that they'll see patients on their own time. And then have them come back for first dose counseling and all that stuff, because they need exposure for their students. They need exposure for residents to have that one-on-one counseling that they may not have, right? So colleges are always looking for sites. So that's also something that I would consider.
That's such a good idea, because obviously we have so many APPs that are in private practice, to your point, that aren't in a large, system. If they're willing to take a pharmacy student, then they get all those additional resources as well. And then absolutely, right? Like no, university-based, pharmacy is going to turn away a prescription because if they can fill it, then that benefits them as well. So to your point, like making those networking is just so important because then you can utilize those services.
Exactly.
So let's talk about the future. How do you see the role of PharmDs in rheumatology evolving in the next 3 to 5 years?
I think with our training programs, especially like with RhAPP, right? We're set out to educate a lot of APPs, and we also specifically call out pharmacy education, right, in rheumatology, which basically makes it more accessible. And I've had, our specialty pharmacists that are within our hospital outpatient pharmacy even take our RhAPP course, right? So that extra, advertisement for pharmacist education, we have a home, um, is going to have a lot more pharmacists more comfortable with rheumatology. But also we're going to have a lot more trained rheumatology pharmacists, right? A lot of more comfortable pharmacists in rheumatology. When I first came into rheumatology, I was not comfortable with rheumatology. We barely got taught, right? But I think especially with now, there's so much education out there. You're going to have a lot more pharmacists that are involved. How that looks, that's all going to change, especially with AI, and maybe there'll be a lot more telehealth, right? Services that you can partner up with. So I think having access to a specialty pharmacist will be more accessible no matter what kind of practice you look like. And then also with the shortage of rheumatologists, I think incorporating that a little bit better into, as APPs are growing in this field, I think pharmacists will have a lot more involvement with those services. So I think it'll be attainable.
Yeah, and it's just more about efficiency, right? Like, and they add such an efficiency piece. All right, my last question for you, as one of our two PharmD board members on RhAPP, what would you want the listeners to know about RhAPP as an organizational home? I know we have pharmacists that are listening, and obviously APPs and physicians and patients. So what can you say about RhAPP just as a home?
So I will say that RhAPP is a great home, and the word is home because it is a place for APPs, but it's also a place for pharmacists, and it's a place where we can network. We have our own PharmD roundtables at our conferences where we kind of all get together, like I said, and kind of just, soundboard on all of our issues that we have with our patients, our payer issues, our, mail order pharmacy issues. So it is a place where we can kind of, sound off on all of our issues and figure out, oh, I didn't know you could do that, right? So having that specific home for pharmacists, I think, is really important. RhAPP as a whole is dedicated to education. And if there is any opportunity for education that you may not be able to get, you can totally approach us and say, hey, listen, I think I need a little bit more education on this forefront, or I'd like to see a little bit more of this. Like we're always, willing to accommodate, whether it's through podcast or journal clubs or anything to increase our knowledge for our members. So I think that out of, when I first started in rheumatology, I actually reached out to Jessica, who is on our board, because I didn't know what to do in rheumatology, right? And I saw an article published by her. There was no advertisement for rheumatology pharmacist education, but I saw a letter or an article that she wrote about pharmacists in rheumatology. So I said, hey, I'm going to reach out to you and find out what am I supposed to do here. So having that now as a home for pharmacists to come to, message us, email us anytime. If you are starting out in rheumatology, we have a mentorship program where you can reach out to me or Jessica or other pharmacists within the field, where we have that opportunity to guide you, right? And help you grow within that field.
It really is truly meant to be, to your point, this home for all of us where we feel comfortable asking questions, getting the education, and networking with other people to just make, not only the career satisfaction higher, just globally. I think we're happier because we work together. So, I couldn't agree more. I wonder if we can link that article to this podcast. I'll have to see, because that'd be really cool for people to just read about, like, what does it look like to be a pharmacist in rheumatology.
Mhm.
Well, thank you so much, Danielle. I really, really appreciate your insights and practical pearls on the role of PharmDs in rheumatology care. Obviously, this is a perspective that continues to grow in importance as our treatment landscape becomes more complex and team-based. Before we wrap up, I want to take a moment to highlight the RhAPP National Conference, which is taking place September 23rd through the 26th at Caesars Palace in Las Vegas, where you'll get to meet Jessica and Danielle. And Danielle will be doing some amazing lectures for us. It's such an incredible opportunity to connect with colleagues, engage in high-impact education, and be a part of the largest gathering of rheumatology advanced practice providers in the country. You can learn more and register at rhap.org. And to all the pharmacists listening, know that RhAPP is here for you. You're a vital role in the rheumatology care team, and we are committed to ensuring that you feel included, supported, and represented. Each year at the National Conference, we host a dedicated PharmD roundtable that Danielle mentioned, and we would love to have you come and join that conversation. Thanks again for tuning in to RhAPPcast. Be sure to subscribe, share with your colleagues, and we'll see you next time.